other month during this time. We're very happy to see new faces here today. And as always, we're looking for interesting topic and the presenters. So if you have any recommendation, please feel free to reach out to me or our team at UCRA, the Great Southern California node. Today, as before, as always, we're gonna do a presentation. We're very fortunate to invite two distinguished speakers actually coming out of our own shop, UCRA. Dr. Tom Freese and Dr. Darren Urada, both from UCRA. Tom Freese has been, I think many of you already should know him. He is currently the director of Integrated Substance Abuse Program at UCRA, has led the training of addiction professional for decades, I would say.
That scares me, Ying, but it's true.
Yeah, same as me forever. So, but Dr. Urada, also the key or lead investigator supporting many of our state California Department of Healthcare Services. Both of them are key players of the California incentive programs. As you know, that contingency management is nothing new to the field. It's one of the most studied intervention in addiction field. Probably research-wise, have shown the largest effect size across the study compared to other intervention. So contingency management itself as a scientific question about effectiveness is probably no longer very questionable or uncertain. It's very certain. So, but the challenge in the field is that still a lot is not widely adopted in the field for practice. It has a lot of implementation challenges, as you know, over the many years. From funding, to policy maker, even general population or general audience. So so it's very exciting to see California actually was able to overcome many of these implementation barriers. Actually are able to, being the first state receiving funds from CMS to do this wide, quite large scale pilot implementation study in California. So we're very happy to have the opportunity to have Tom and Darren to discuss with us the lesson they learned. The reason why I invited them is that even though as it's currently implemented, it may not be very, incorporating telehealth or telemedicine procedures, but its implication is very wide. I hope that after the feasibility or pilot study, it has a wide implementation potential or possibility, and very likely take advantage of the current development that can be benefit many of our population. So without further ado, Tom and Darren, it's your floor.
Thank you very much, Ying. It's nice to see some familiar faces on the line, and thanks for that very warm introduction, Ying. I really appreciate that. I also love that you have a pit bull. I didn't know that, and the breed is very fond of to me. I have one too, and it was nice that he or she made a little cameo appearance.
He doesn't like to be ignored.
That's what mine was doing when we were logging on, so I understand completely. I'm really happy to be here today. I'm only going to spend about 10 minutes and then turn it over to Darren, who I think has much more relevant information to share for this particular group. But I wanted to give context for what it is that we're doing in California, and why we think it's important. As Ying said, I think we're not quite ready for prime time with the telehealth implementation of this, but we will talk about some future implications and where we think expansion is possible as we go along, and what some of the current limitations are in implementing it. As Ying said, there's decades of research that have gone on quite literally that have demonstrated the efficacy of contingency management in research contexts. The problem is, because of funding related issues and frankly because of fear of being accused of fraud or kickbacks with public funded dollars, people have been very reticent to implement contingency management on a large scale basis. Either they're afraid of getting in trouble, or the resources just aren't there available in the public funded system in order to be able to do that. So the decades of research has been summarized in a number of meta-analyses that have come out over the last couple of years. And I thought I'd just flash a little data in front of you that says contingency management for cocaine is the single best treatment that we can provide to them. And the same is true for methamphetamine. With a large number of studies looking at a variety of outcomes, we see a significant reduction in methamphetamine use, longer term retention in treatment, higher number of sessions attended, reduced sexual behavior, increased in quality of life, etc. And again, evidence suggests that if we're going to do one thing and one thing only for someone who's using stimulants, we should be giving them contingency management. The additional effect that you get from adding other behavioral treatments on board, particularly if they're evidence-based treatments, you do get some added benefit, but most of the variability is taken care of through the implementation of this one intervention. In my brain, this makes this the single largest failure of implementation of research findings into public settings that has ever happened. On average, it takes about 17 years, which is terrifying for an evidence-based practice to make its way into the field. But we have 30 or more years of evidence that demonstrate that this works, and yet we're just beginning large-scale rollouts in this particular case. Another advantage of contingency management, it's been tried in a variety of different settings with a number of different cultures and subgroups, Native Americans, in several countries around the world, with men who have sex with men. And as long as we make the incentive relevant to the individuals that are receiving the intervention, it seems to work effectively regardless of the subpopulation that we're talking about. And it's been shown to work with populations who are dealing with co-occurring mental health related issues. One of the biggest problems that we faced as we were looking at implementing the California program is really overcoming sort of all of those barriers in order to be able to implement the program effectively. The resistance in the programs, particularly very traditional programs who do primarily group and individual counseling, looking for complete abstinence, there was a lot of pushback from people saying, we can't be paying individuals not to use drugs. And really, that's not what we're doing. While we're using concrete incentives, we're doing very basic operant conditioning to make something other than drug use rewarding, so that we can begin to combat the rewarding effect associated with that ongoing use of the substance. By rewarding and giving successes for something other than substances, we see increases in self-efficacy, increases in the ability to stay away from the drug, and commensurately, we see longer periods of time without using the drug so that they get the opportunity to see life itself can be rewarding. There are lots of funding barriers, as we talked about. SAMHSA, as a way of trying to help avoid the Office of the Inspector General concerned about waste, fraud, and abuse, put a $75 per person per year cap on the amount that could be used of federal funds to provide incentives to individuals. There's not a single bit of research that that's based on. In fact, all of the researchers say this can't possibly work at that rate. And in fact, officials at SAMHSA and other governmental agencies recognize that this cap isn't going to be effective if we're going to implement contingency management. But they haven't overturned the cap either. The political process is what it is, and it takes a really long time in order to be able to make those kinds of changes once they're implemented. So what California did is they circumvented a lot of those problems by including contingency management in the 1115 waiver. And what that allowed them to do is to make it, through this demonstration project, a fundable service under Medicaid, Medi-Cal in California. And as long as someone was able to bill drug Medi-Cal for those related services, they could be included just like every other Medicaid service that's available to California residents. In that, it overcame a lot of the payment issues. We had the protection of CMS and the Medicaid system, and we're able to implement a much larger program. So in their wisdom, California said, we should just do a small pilot. And by that, they meant 24 counties, 166 sites, all implementing contingency management at the same time. It was a daunting task to figure out with my team how to do the training and implementation support in order to make sure that not only are we doing this rollout, but we're implementing in the wild, as it were, in community-based treatment programs, an intervention with research levels of fidelity to make sure that we give it the best chance of working and that we don't run into any of the problems of concern about waste, fraud, and abuse that might negatively highlight the program. So the program that we put together is 24 weeks in length, an intensive portion for the first 12 weeks where they come in twice weekly and receive incentives for any urine drug test that is negative for stimulants. The second 12 weeks is kind of a stabilization phase, and we reduce to once a week and a flat testing schedule during that period of time as a way of trying to keep them engaged with the treatment system while staying within the financial limits that have been imposed and kind of tapering them off of the contingency management while they're still getting that support. We do test for a variety of drugs, either 12 or 14, depending on the test that the organization selected. But the incentive is only based on the stimulant results, not any other substance. And again, that's an evidence-based finding or evidence-based decision that was based on the fact that if you focus on one drug, you seem to get good results with that drug and some spread of effect to other substances as well. But if we do things like require complete abstinence, we don't get enough instances of them being completely successful for the intervention to work. California, for lots of reasons, set the maximum at $599. Again, that's lower than most of the research that was conducted, but there were concerns about this becoming taxable, being considered taxable income, and therefore requiring tax reporting and potentially driving the person off of the benefits cliff and making them ineligible based on the amount that they receive through this particular program. And so to minimize all of those risks, they've capped it at $599 pending a ruling from the IRS as to whether or not this is considered taxable income or not. They promised us that ruling in June of 2023. We're still waiting. And finally, a piece of technology that's included in the program is the Incentive Manager, which is a web-based portal that allows access from anywhere for whoever has the login rights to the portal. And it tracks the incentives and delivers the incentives directly to the individual. Incentives can be delivered via text, email, or printed. The 24 original counties are listed here. 23 of them are still participating, and these are the counties that we've been able to launch at least one site in so far. There are some barriers which we can talk about later, primarily administrative barriers or the need to get CLIA certification for the site that have delayed people's implementation. Just a quick review, a very quick review of what is contingency management and how do we do it effectively. We really came to understand that it has four essential ingredients. We need a very specific target behavior that we can measure very accurately. In this case, non-use of stimulants is evidenced by a negative urine drug test. We need to measure that behavior frequently enough that the reward gets delivered as often as possible. And we need to provide tangible incentives as soon as possible after we receive that reward, or after we observe the behavior, I'm sorry, so that we see the test, we deliver the incentive as quickly as possible. And we need to make sure that everything is sensitive enough that if we don't see the behavior, we get a positive result on the urine drug test, that we withhold that incentive while maintaining a supportive attitude. What we want is an all positive intervention, not a negative intervention. And the only cost is really you don't get incentivized on days that you don't demonstrate the behavior. And there's a small financial hit in the way that the incentives are delivered, but that recovers very, very quickly. So I don't have time in today's presentation to go into great detail about how we implemented this thing, but I just put these 5 steps up there so you can demonstrate, so I could demonstrate the degree of support that's required to implement something with fidelity in the community. Very often when we implement evidence-based practices, we train them to fidelity, and then we send them out into the field, and we may do some check-in and monitoring to say, are you doing it right or are you not? But like with CBT, we say, are you doing CBT? Here's a checklist, let's do that. And very often we don't have the kind of support to observe them directly doing these behaviors, for instance, to make sure they're doing it with fidelity. So we start with an overview training that everyone in the team can participate in. Then those that are delivering CM are required to do 6 hours of training on the implementation of the protocol. The site then takes that protocol back to their own location, walks through every element, and describes how they're going to implement that protocol in the context of the flow and structure of their particular clinic. They also have to insert cases into the incentive manager portal so we can make sure they can do that correctly. And then we have a virtual face-to-face meeting with them to talk through all of that, address any concerns that we have, and make sure that they're ready to launch with fidelity. Once we do that, we give them the go and they can start providing services. Monthly after that, they have to, all staff delivering contingency management have to participate in a monthly coaching call via Zoom. We offer 10 a month right now so that we can accommodate the volume of people that are participating, but they have to participate in at least one of those per month. And twice within the first 6 months and once every 6 months after, they have a fidelity monitoring visit with us, which again includes a self-assessment portion and an interview portion so that we can monitor whether they're implementing with fidelity. It's a lot of support that's needed. And as you'll see from Darren, it turns out they're doing really well. I'm going to end with just a couple of my thoughts related to telehealth and how it plays in there. And Darren's going to present some much more direct information about the research that's been conducted so far. We have to use telehealth if we're going to roll this out in a major way, particularly if we're going to hit rural America. You can't be expecting people to drive 2 hours to the local clinic twice a week in order to get the intervention service that's there. There are apps that help facilitate this process, but I think those apps need more development in order to make them as acceptable as possible to people. The other thing is we need to look at testing options if we're going to use something like a negative urine drug test, and how we can deliver those. Most of the research that's been done on telehealth has been using saliva tests, which is great in a research context, but in a public funded health system, all of the tests that we use have to be CLIA waived in order to be used. And to date, according to some work that we just did, there are 0 CLIA waived saliva tests that are available, representing a significant barrier in public rollout. We need better strategies for monitoring test compliance and accuracy to make sure that it's actually that person's test and that they're not adulterating it in some way. And non-research implementations have had some difficulty with recruiting patients into participating in some of the apps that are available. So I think there's real hope on the horizon, but there's some development that we need to do in order to be able to do this in a meaningful way. And I think some of the research findings that Darren will share with you after we look at what we've learned from the California project points us in the direction of where we need to head in order to make this more meaningful. So with that, I'm going to stop sharing and let Darren take over. He's going to talk a little bit about what we found from the California project and then the telehealth implications. Darren, over to you.
I think you're muted.
Yeah, sorry about that. Can you guys hear me?
Yes.
Okay, great. Got too much stuff on the screen. Thank you, Tom, and good morning, everybody. Thank you for being here on a early morning, Friday the 13th. We appreciate it. I'm doing my least favorite thing to do, which is follow Tom, who's always a great speaker, but I'll do my best. So you'll see here, we have a large team that's been behind this, working on this evaluation, and we've been working towards this really for a long time. We've just started to present these findings, and we're looking forward to any feedback that you might have, because we've got a ways to go on this, but this is part of a rollout that we really think the rest of the nation needs to see in order to hopefully follow what California is doing. So today I'm going to talk about provider and client surveys, urine drug test results, and we'll talk a little bit about interviews that we've done. And then, as Tom mentioned, we'll get into how this all ties into apps and telehealth in the future and how CTN might actually play a role in that. All right, so just some basic numbers. This is the enrollment in the Recovery Incentives Program to date, or at least through July 2024. We've seen about 3,605 people through the end of July. So this has really been ramping up, not only in the absolute numbers that you see here, but if you look at how much it's going up each month, that's also increasing and accelerating over time as programs launch and start participating and continue doing so. All right, so how's it actually going once they start? This slide's going to take a little bit of time to set up. What happened was all participating providers went through a great deal of training and coaching, as Tom has described, and we think that's important for the implementation. And as they did so, we recorded the concerns that they brought up during these trainings. And you see them here on the left side. Then 5 months after they finished the training and they actually launched, we sent them a survey asking them, well, how frequently did any of these things actually happen? So what you'll see here is if it's in red, that means it happened often or always. If it's green, that means it was it was never or rarely. All right, so what we got was this: almost always, never, almost always, rarely, and never. There was a little bit of concern about staff time and effort. Even that was around 20-something%. So some of the initial fears just failed to occur in reality. All right, what else did providers say? We asked them about the sufficiency of the DHCS-sponsored trainings, or basically what Tom's group does. 91% said it was mostly or completely sufficient. Yeah, we asked, do you feel qualified or properly trained to administer contingency management? 88%. We asked them to rate the incentive manager software, and 92%, good to excellent overall. Does it have an impact on client engagement with other services? 86% said yes. So this is fairly extraordinary to me. It's hard to get 90% of people to agree on anything these days, but it looks like that's what's happening here. To back that up, we then went out and asked for a little bit more information by interviewing people, getting some stories, and we have a few examples here. We had a client who was able to save up for a nice bicycle for her kid. She took a video of her kid riding around on her bike, and it was incredible to watch her grow and get excited. We had one person come in just for CM. So this is common. They start for the incentives, but the important thing is, why do they stay? He participates in our outpatient program pretty regularly. Even if there is some hesitation, we've seen his ambivalence turn to pre-contemplation, and it's actually working. His brain is being retrained. So this is the kind of thing that we hear from providers a lot. They start to see what's going on. At first, I was against the program, but when I started seeing the clients and their results and hearing the stories, it really changed my perspective on the program. So that's where the providers are at. What about the clients? Did Recovery Incentives Program help you to stop using stimulants? And you see 93%. And not only did they provide these ratings, they also left a lot of comments. Nearly 300 people left a comment out of 547 respondents. So it was at the end of the survey. It was optional. We never get that. Usually we get a handful of comments. So I really appreciate this program. It helped me clothe my children. It was awesome, and it saved my life. Having to test twice a week really helped me stay sober. I'm here for the gift cards. I don't think this helps me be sober, but my outpatient really does help me. So that goes with what some of the providers were saying. If it keeps them in the program and keeps them engaged in counseling and other parts of the program, that's a win too. More results from the clients. Has your health improved? 94%. How much better are you at taking care of personal responsibilities? This is from the treatment effectiveness, the TEA that Walter Ling and others helped develop. Treatment effectiveness assessment. How much better are you at taking care of personal responsibilities? 97%. Are you a better member of the community? 97%. So incredible, right? So, okay. So that's all subjective. That's fine. What about drug test results? Among those test samples that were submitted, what we get is 96% negative. Now that, even to me, I know that's rather high. So you could look at this and say, well, okay, if they knew that they had used a stimulant, they probably didn't show up for the testing, right? Some did. Some tests, we have some people who showed up consistently and tested positive the whole time. But okay, what if people are just skipping tests? What we can do is we can assume conservatively, we can treat unexcused absences as if they were going to be stimulant positive. So that's a little bit conservative. That wouldn't have always been the case. Some people just missed the bus or whatever the case is. But if we do that, then the number is 74%. So that rate is somewhat better than comparable measures reported, not only in the regular SUD literature, but also in the contingency management literature.
Darren, can I pop in for 1 second?
Yeah.
I think this is really important because most of the research that's been conducted has used this more conservative number of 74%. And our rate here, as Darren just said, it's higher than what we're seeing in a lot of those particular studies. The VA, for instance, has numbers that are just under 50%. I can't remember the exact figure, but just under 50% using the same measure for a rollout of contingency management. But we also are working with Darren and a number of experts across the country to look at measures of engagement with the service and to see kind of what a better treatment way of looking at this particular data would be, rather than these pure kind of cold research, it's on or it's off kind of examinations of these studies. So I think we'll be able to refine these data a lot with the work that Darren is doing and get an even deeper understanding than we've been able to gain from the research in future evaluations.
Thanks, Tom. Yeah, the VA number that's sort of comparable to that 74%, they included unexcused and excused absences. So that makes it a little bit lower, but the comparable number is 48.2%. So,
and when I did that on a rough count around the same time that Darren ran these numbers, the number went down to 72%, but it was still above 70. So I don't want to print those numbers at this point, but I still think we're showing pretty good results, even if we're including all absences.
Yeah, and that's also in the California's cases over 24 weeks, whereas a lot of the trials were over 12 weeks. So pretty good. I would say the true number is probably between 74 and 96. I don't know what it is, but you can take an average or something. It's probably not far off. All right, limitations. It's early. A lot of the programs and counties that are participating were early adopters. A lot of them were in Los Angeles County. Many clients were already in treatment, relatively stable when they then transitioned over to the recovery incentives program that could change over time, but we're monitoring that to see. so the survey participants tended to be people who were there when we did the survey. So there were people with better attendance, so that could bias things a little bit. Neither surveys or urinalysis, of course, are perfect measures. There's things that could go wrong with either. But still, overall, very positive results. And the other thing we found that providers are, as I said, a lot of them are in Los Angeles, mostly in urban areas so far. It's only a very small handful of rural sites. And attending in person can be a barrier. So the next step is to look at what else can we do. I think it was important to roll it out in person, very tightly controlled, good trainings, and make sure that worked. And we're urging caution as to the next steps.
Oh man!
I'm going to show here's some recent articles on CM for SUD. There was also some smoking apps, but I left those out just for the sake of space here. I know this is very small, and the conclusions from the smoking apps I think were similar. So what you're saying here is these findings are feasible, acceptable, satisfactory. Whether the benefits are yet to be established, talk about potential. This one study by Stitzer et al. 2024 actually provided some negative results. Engagement with saliva sample submissions were low. I think it was around 20%. So that was a very small study. This is a CPDD poster in Montreal this last summer, but I think it's really important for us to know that there are possible downsides if we try to roll this out too quickly because we want to use apps or telehealth. There are things that can go wrong. On a similar note, on remote oral fluids testing, it was adequate for some drugs, but not for others, including amphetamine. So the fact that we're doing this with the methamphetamine, that could be a problem. Often what people do with these apps is they will do a saliva sample on camera, and that will serve as the basis for the incentives. And as you might imagine, there would be problems with asking people to provide a urine sample on camera. So that's why we want to go with saliva. But if there are issues with the reliability of those samples, that's something that definitely needs to be considered before we move forward. So right now we're basically in the feasibility, acceptability phases of the research. There is a study down at the bottom, if you can see it, Hansen and Shire, that looked at NIH funding for smartphone intervention apps. And there were 24 just in this from 2014 to 2018 that were funded through NIH. So there is, I think, a tremendous amount of interest in funding these things. And those studies, I believe, helped create all of these acceptability and feasibility studies. But we're not there in terms of effectiveness, I think. So CTN, maybe you can help with this. And that brings us to the end. And I did see there was some questions.
Yeah, one of the questions from Nicole is, I'm curious about what the maximum amount of incentives were in the studies that demonstrated that CM works. The research varied a lot from about $300 to about $1,600. If you look at kind of the average, it was somewhere between $900 and $1,200 that most of the studies used in terms of their match. So our number at $599 is within what has been researched, but we seem to see an effect of the larger the incentive, the more powerful the intervention is. And so California is open to the idea of increasing the rates of incentives should we get that ruling from the IRS that it won't cause them other problems down the road. One other thing I'd like to note as you think about additional questions or conversations that you'd like to have is that the largest rollout to date outside of research context is being done in the VA. I think Larissa is at one of the sites where that's being conducted. It was implemented initially in 2015 and has been offered in VA programs across the country since that point. And according to a paper that they just published, their enrollment is about 6,000 people over the course of that amount of time, with most of them coming in since COVID, but not all of them, certainly. In about 16 months, we're at 3,600 enrollees in the California program. And so I'm looking forward to later this year becoming the single largest rollout of contingency management. And the VA has the advantage of all those protections of the governmental structure that we don't have in the publicly funded system. And so I think, as Darren showed from the data, but also just from the rate at which people are coming in, it seems to be a very successful implementation project.
Thanks so much for the great presentation. I have a follow-up question about incentives and then also a question about the patient population. For the incentives, were the funds for the incentives coming from the program, like the pilot program, or were they like claims being submitted to Medi-Cal? And do you have any insight into whether these services are currently billable in any Medicaid systems, or is it really like using research funds to try to implement it at the moment?
You want me to take this one, Darren?
Sure, go for it.
The state of California implemented funds specifically to cover this program through some state general fund dollars, primarily for startup money, and to cover some of the non-covered expenses related to incentives. The service itself is completely billable. There's a Medi-Cal billing code with 15-minute increments that's designed to cover the cost of the service in terms of staff time, but also urine drug testing and other supplies associated with that. In California, each county negotiates those billing rates directly with the state. So the state put up a range, but if the county says that's not enough, the county can negotiate a different rate outside of that range. I frankly don't understand the complexities of funding the incentives in that, and it is a combination of federal and state money that goes into the funding of those incentives, but it is not outside of the program, and there are no research dollars that are being used in the implementation of the program.
Got it. That's helpful. I'm at Work at Health. We're a large telehealth provider for substance use treatment, and we've tried before to do a contingency management program, but we were limited. It was really hard to figure out this compensation piece, and our incentives were only like up to $50 a year, which made it like not meaningful, right? So that was
in the current structure, you would never be able to do with using federal dollars or any kind of public health funded dollars, which all come from the feds. It's any more than $75 per person per year until that cap is overturned. So as a healthcare agency, you advocating with your legislators and SAMHSA and others, send horrible scathing letters about people dying to SAMHSA. They're actually being paid attention to, and they're trying to use it as fuel to overturn that $75 cap.
Or collaborate on CTN studies to study.
All that.
Okay,
and all of the above.
My other question had to do with the patient population, and if you have a sense of how many patients had opioid use disorder and whether there might be any effect modification by opioid use disorder and like receiving buprenorphine, and just kind of like who are the people that are kind of enrolling in this program?
I'll answer part of it and let Darren see if he has any data at this point related to that. It was treatment as usual. It was whoever the client population is and whoever they could recruit in at the sites who volunteered to participate. So it's a broad spectrum of people in treatment. We do know that in many of the outpatient or intensive outpatient programs, people have used opioids, and that is one of the substances that they use. Although I don't have rates associated with that. Darren might or will eventually. Also, two of our sites at this point, and we have two more that are slated, are OTPs. And so it'll be interesting to see what we can learn from comparisons of those two or more sites to the rest of the program who aren't specifically providing treatment for that disorder as we move forward. But right now I can say they're in there and we'll be able to tell you, but I can't right now. Maybe Darren can. You have any more to add to that, Darren?
I unfortunately don't have a lot either. I do, just off the top of my head, I believe almost all of these sites, all almost all of them are not non-OTP so far. So yeah, probably a lot of people do have OUD, but we'll know more once the OTPs start joining. We've also heard from the providers that when people stop using stimulants, they tend to also stop using their other drugs because they actually have the drug panel on the urine drug test that they use. It covers all of them, not
12 or 14 drugs, depending on the panel.
Right. Unfortunately, we only get data on the stimulants. And I think that was a decision just to reduce their reporting burden. But I would love to get my hands on at least some of that.
I think the rest of those data will be available through the rest of the regular Medi-Cal billing systems. As they put in diagnostic codes, et cetera, we'll at least know who's using opioids. Whether or not we'll ever get to the level of getting those individual tests associated with that, I don't know what's available there. But we will be able to do some comparisons of those who we know have an opioid use disorder and those who don't, because Darren has access to that information. It's just there's a big lag between starting, and when we get access to those data.
Yeah, exactly. We have access to Callum's, which is TED's data for nationwide. So we'll be able to see what their primary and secondary drug problems are, and then we can track that against their outcomes.
Lillian had a question about why does CM not work? What's associated with it not being effective?
Well, if it doesn't get implemented, I think Tom's mentioned of there's staff turnover, staffing issues, and CLIA waivers that stop the program from being implemented. And there are also some programs that they feel it's a lot of requirements to meet for if they're a very small program, they don't have a large number of stimulant users. They wonder if it's it's worth going through all that to implement it for them.
Yeah. For the programs that have volunteered and have not yet implemented, it's either staffing, they're having trouble finding the staff in order to be able to do that, or the CLIA certification process, more the CLIA certification process than staffing, actually, according to data that we're just looking at. Because each site has to be CLIA certified and have a state lab registration in order to administer these tests on site as well. So that's the biggest barrier. I think for some people, it doesn't work because they're not ready. It doesn't work because they're focused on other things. I don't think we've seen anything systematic, at least as reported by the people who are implementing it in our coaching calls, that leads to some people failing out of the program. Certainly the twice a week in the program is a barrier for many people. And we've had some people, for instance, get a job that conflicts with the scheduling for their testing, and they can't accommodate coming to the clinic twice a week. And so they withdraw from the program. It'll be interesting to follow some of those trends across time and see what impact that may have had downstream, as evidenced by other data that we have. Don't have a good answer to that yet, but it's a great question that hopefully we'll be able to answer more. Cindy, you had a question about the portal?
Yes, I have many questions about the portal, but I will try to limit it. Well, okay. First of all, I want to thank you, Dr. Freese, and thank you, Dr. Urada, for putting together this great presentation for us. And the other thing that I wanted to mention, because I think the helpful piece of this is the portal portion of this implementation, because it's such a large endeavor. And I think one of the items of resistance that at least I've seen coming from working in an outpatient setting is, how are we going to maintain the operations of this? With the portal, I did want to ask, who has access to the portal? Is it just the clinical site? Is there any oversight of that portal? And then who has the intellectual property as well?
Excellent question. DHCS owns the intellectual property, but the evaluation team has rights to those data in order to be able to do and conduct the evaluation. Is that correct, Darren?
I mean, it is run by an outside company, Q2Y, that DHCS contracted with. So I'm not sure how the intellectual property
I believe that the contract is set up so that DHCS owns the intellectual property, but that is still a question. Who has access to it? The providers who are conducting the service have access to it, as do at least one supervisor at each site who can look at their own site only in order to monitor data. The county lead team at each county, which is required, have access to a read-only and reporting version of that so that they can monitor who's coming in. And then DHCS has access to the portal on a read-only basis. We have access at UCLA in the training side to a read-only version of that. And Darren has access to that and later to the full data set associated with the information that comes into the portal.
Awesome. Thank you.
Yeah, you're welcome. Can we offer implementation support in New Mexico? We have offered consultation to a number of states across the country and are actually contracting with one other state. The contract's not in place, so I can't say which. Right now, we're in the process of finalizing that contract to offer full implementation support for them. And so is it possible and or feasible? As an individual consultation, we would do that just to help you out. If you wanted something more, we'd have to talk about costs associated with that, but certainly it's possible. Katie, you had some questions about staffing.
Yeah.
Nice to see you, Katie.
Yeah, it's good to be here. This is just really exciting. But I have a lot of thoughts. So the training, what does that include? Is there, we all know that the relationships that our patients have with whoever they encounter is often at the heart of why they come back, why they build more, strength in their choices. So I was curious, how is the training motivational interviewing? Is it scripted?
Yeah, it's a really good question.
Yeah, I'd be interested.
We start with a self-paced overview. It's 2 hours in length, just so that people have the basics coming in to the implementation training. That's open to everybody, by the way. So if you're interested in what we did for our self-paced overview of CM, we can provide that link to the CTN staff, and you're welcome to log in and take that. The implementation training is only for people who are implementing it. We've allowed some guests in as well. So, again, if you're interested, let us know. But it's 2 3-hour segments. The first really about how to implement the protocol with fidelity. The second about using the incentive manager portal and all of those complex clinical scenarios that can come up in relationship to implementing this kind of intervention. It is not scripted. They're all live trainings that are done in real time by expert trainers that we've developed locally. In order to be able to have that interactive quality associated with it. So it is not purely didactic, it's an interactive training experience. The readiness assessment also includes putting the information into the portal based on 3 very complicated cases. And when we did them, no one on my staff, including myself, got them right the first time we put them in. And so we work with them to make sure they get 100% score on each of those cases. And during the readiness assessment, we actually walk through every clinical scenario to determine how they made the clinical decision of what went into the portal and make sure that they're in line with our thinking and that it wasn't just happenstance that got them the right answer. And finally, I think the real training happens in the coaching calls, which is an interactive learning process, multiple people from multiple sites telling on themselves and talking about what difficulty they have, and then doing group learning and consultation with one of my staff always being on board to make sure that they come to the right answer in terms of the protocol, but figuring out how to do that problem solving along the way.
Wow.
So it's a lot.
It is. It's very thorough. And my other question is, how many or how frequently were the participants also part of an outpatient treatment? I mean, where did that interface at all with the CM study?
Try your question again. I'm not sure I understand.
So let's say somebody is in outpatient in Nevada County and they have signed up. They're in treatment, and
yep.
so it was Was that also part of what we were
Absolutely. So anyone who's currently in treatment who had a moderate to severe stimulant use disorder, they were already in treatment in an outpatient setting, so we knew that that was appropriate for them. And an LPHA indicated that treatment for stimulant use disorder was medically necessary, could be enrolled into the Recovery Incentives Program. We've had some people who've been quite successful in their outpatient program, but are still being treated for a moderate to severe disorder. And so they may not have had recent use and they would still be eligible for that. If people come in and they're currently in remission for their stimulant use disorder, it's a harder case to make. But if the LPHA makes a case that treatment is medically necessary for them, they can also be enrolled in the program. So the initial pool at each agency was primarily people that were already in treatment. And so we thought what was going to happen in our recruitment curve, it was going to go up, it was going to flatten off, and then it was going to start to go down, just like we see in all of our research studies, that infamous research recruitment curve. We've got kind of almost a logarithmic curve happening here. And not only are we getting more and more people in all the time, but that number is going up and up at a steeper angle as we continue to roll out the program. So we think we're drawing in more, we're certainly drawing in more programs, so that's part of it. But we also recognize that we're probably drawing in more people from the community who wouldn't have been in treatment otherwise.
Thank you. And one more, were there any tribal communities as part of this? Because this was county, so probably the answer is yes and no.
In DMC ODS counties, there is only one DMC ODS tribal program in one county, and they have chosen not to participate. And so it's a big barrier to including them. In the most recent behavioral health information notice, DHCS is making the changes to include the partnership health plans as a DMC, as a county entity, in essence, in the way that this program works. And so anyone that's receiving services through partnership can be eligible for these particular services. They haven't figured out how to do that yet, frankly. The BHIN just came out, but I think that'll open the doors to some of the tribal organizations in the trees and in the desert that right now aren't able to access the service. And I've been pushing for that for over a year as a way of trying to get more tribal representation. So I'm thrilled that we're moving in that direction.
Thank you. Wonderful.
Who's providing the CM service at this point? The regulations say it has to be a Medicaid billable provider or another professional providing services under the license of a billable provider. So we have all the normal billable providers, but we also have some administrative people who are just really good with details and really nice. We have some non-licensed or certified counselors or peer navigators, kind of across the spectrum in terms of who's providing the service. We don't set any limitations on that. Some of the counties have regulations about who could provide those services. Some of the sites have regulations on who can provide those services. But as far as we're concerned, if they can come to the training and get through the training and get their cases into the portal accurately, we are happy to train them and support them in implementing the service. Because again, I think that's necessary if we're going to do this in real time, because they're in a physician's office in the world where the doc is going to be delivering this particular service. We have to figure out how to use the supportive medical staff and the supportive behavioral health staff in order to implement this, in order to get widespread utilization. It's a great question.
I think this is a really interesting question, because early on, we talked to a number of people, and Rick Rawson actually recommended that this not be a counselor position because it's a very different role. The way I think it's rolled out is very. Sometimes what happens is a program has existing staff and they will add it to their tasks. And I think that, given our staff shortages, is completely understandable, and it's probably, if they couldn't do that, probably some programs wouldn't launch. So I'm not saying that's a wrong thing to do. At the same time, we have to recognize that makes it hard because it's just being added on top of other things that they're doing. So it's something that we're struggling with right now. Like, should there be dedicated staff? Well, in an ideal world, it would be nice, but
It was set up that way originally. We set it up so that there would be a CM coordinator at each site with someone providing backup coordination to them, and then a supervisor who could oversee the program, but also serve as a backup should the other two not be available. Those three roles are required to be identified at each of the participating sites. But as Darren was saying, sometimes that role is also a counselor who's got their own caseload on top of that. And I would say the sites that we have the most difficulty with in terms of hiccups related to fidelity to the protocol that we have to figure out how to both coach them into not happening again, as well as figure out how to fix some of the issues that come up, are those who have dual roles along the way. Even just answering questions like, at what point does the CM session stop, that billable session ends, and this counseling session begins? If it's the same person in both of those roles, that becomes a real challenge for that individual. Conversely, the sites that have leapt out to the front and are the most passionate about it are those who've been able to hire a CM coordinator that's dedicated to that role and use billable income that's coming in order to be able to support the costs of that particular role.
I think that's a very interesting point, and thank you for a great discussion so far. I think the thing is, if who play those roles and how you treat CM as a separate or independent component of the therapy, that's the distinction. If you treat that as an independent, separate intervention that's not integrated with the therapeutic program,
yeah,
perfectly fine. Anybody who can do so should do so. But if that say urine results or even incentive can be part of the counseling, that I would think have a stronger impact, because we all know when incentives on the behavior, may be able to maintain, but after the incentive is out, then the effect disappear. I think that's the major problem with the research perspective.
Let me contradict that just a little bit from what we know from the research, which is at 1 year follow-up, when people only got CM, we see a lasting effect of the contingency management at a rate that's about comparable for someone who went through a research trial of a behavioral counseling intervention, and then we follow them up at 1 year. These effects are ongoing and lasting for the individual, in spite of what we would think is true. Now, do they keep people away from drugs altogether? No, it's a lifelong condition for many people. They need ongoing support. So stopping treatment and altogether and then evaluating them a year long is a problem that we created in the whole research, the way that we research addiction.
Yeah.
That being said, people in the Recovery Incentives Program can participate only in recovery incentives if they want to. But we've purposefully embedded it in the context of an outpatient service so that when they struggle with it, when they realize it's not meeting all of their needs or life just is a bummer, and they want to get some counseling support, they're already enrolled as a client in the program, and they can simply step across the hall and get those supports as well. And we think that's the best strategy for implementation.
Yeah, we need to compare notes. Most research results are different from your perspective.
Love to compare notes with you.
But in any event, I'm just saying that a lot of apps are now available and also include the CM as in addition to the. As a matter of fact, in CTN, there are trials like the retention and the continuation, discontinuation trial that has the app with the medication and everything. And the app is part of, CM is part of the app. So I think that interest in CM is definitely and recognize its effect is widespread. It's no question. It's how to make it the effect stronger and last longer. It's the current trials trying to get. But I think the California trials, effort is so unique and great. Is that it's more than pragmatic trial. It's everybody that's interested that can get it, and the app is not commercial, so you don't have to wait until insurance approve for your use of app. to use that app. So, and the burden is all on the government and the supporting system. So I think that's a very different perspective from most trials that NIH support, and that's why it's so unique and wonderful.
I'm really looking forward to the CTN trial and what we can learn in addition to that. There's a number of other research studies that are being thought about. Howard's looking at doing a PCORI study on the California rollout as well. And so I think there's lots of opportunity for us to figure out how best to put this onion together so that it's the most meaningful thing that we can. Really appreciate the opportunity today.
Yes, I was hoping to generate more interest from the CTN that California already doing this. CTN maybe if they are interested, we can help them to develop some protocol to compare and actually expanding more to the telehealth telemedicine.
I'd love to be involved in that, Ying. So keep me posted on how I can help.
Thank you so much. It has been a wonderful presentation. I really appreciate it and a wonderful discussion. And thank you everyone for participating. I see you next time.
Lovely seeing you all. Everyone. Cheers.
Take care. Bye.
Thank you. Bye-bye.